this gentleman, I can't actually remember how old he was. I'm going to say somewhere between 60 and 85. He actually was sent in for an echo looking for infective endocarditis, and then we noticed something else. So should I pick on people?
Yeah, definitely. And if we need, you can pick on Hatton behind us.
Hatton, why don't you talk about this image?
We've got Emma Bocock, our new Echo Fellow next year. She definitely needs some questions. Okay. Sid, yeah, everyone. Swapnil's been quite, all of them. They love it.
Okay, so that's the longest personal view so the main feature that I can identify that there is concentric left ventricular hypertrophy. I didn't measure exactly, but looks at least exceeding the lying in the moderate zone. I can clearly identify the mitral valve with both mitral valve leaflets opening and coaptation line is good. I can't really see much of the aortic valve. So,
why is that?
So it's either image acquisition, so probably needs more rotation.
Oh, criticism of the student. That's controversial. Yes.
Or could be, I need to see it in other view, or could be occupied or overlying with other mass.
What's this?
So that's the. I'll go further into the history, identify whether the patient had any prosthesis placed in the past, but looks like mitral valve prosthesis. Aortic valve prosthesis, more likely it would be biprosthetic, given that there is no acoustic shadowing out of it. Right ventricle at flow tract looks normal in size, and I would like to confirm this with different views.
Good. So this is.
Very nice. So can everyone hear Hatton when he's talking? By the way, is that okay? Cool. Thanks.
I can take them off.
So
so aortic valve prosthesis, biprosthetic in nature.
Yeah. So stented biprosthesis and thick LV, exactly.
And probably there's a few V-lines on the far field.
Yeah.
Quite good example of acoustic shadowing down through the LA there as well from the bio.
So if you see a thick ventricle like this, and you're thinking, oh, he's probably got pulmonary edema as well. What part of heart function are you going to look at?
So basically looking at the diastolic dysfunction, pretty much. Systolic function looks relatively okay.
It looks not too bad, right? I'll give you a better view of the aortic valve just to show you that this, in a parasternal along the stent of the biprosthetic valve will shadow the rest of the valve, so you can't actually really make much of an assessment of the valve leaflets themselves. You can look for regurg on colour going into the aorta, and that's about all you can do in this view, so it's important to get it from lots of different views, and preferably a toe when you're looking at biprosthetics or prosthesis of any kind, really. So let's move on to the diastology. Yeah. Okay, so
that's TDI across the septum at the mitral valve level, and that's showing an S prime of how much? Of 5?
5, yeah,
okay,
5 centimeters, yeah.
And E is 5. Yeah, so
and then
everything is reduced, including systolic and diastolic dysfunction, but probably we need to complete the criteria for diastolic dysfunction with TR, left atrial size.
Exactly. Yeah. And on the lateral,
they're
low as well. Yeah. And then something I only recently learnt about is the 555 rule.
Yes, so it will give possibility for amyloidosis.
Beautiful, beautiful. So what would you do next? Strain. Okay, cool. So,
sorry, Benny, what was that rule you mentioned?
So if you have all of your velocities on your tissue Doppler, so your S wave, your E prime medial and lateral, they're all 5 or less, 5 centimeters per second or less. That's the 555 rule. and then that leads you to have a strong suspicion for amyloidosis or cardiac amyloid disease. And if I can get okay, so that's and that's the EA ratio. Yeah. Okay.
1.6.
So let's go straight to strain. So I just want to go back to this picture first. What else, knowing what you know now, what else would you look at?
So looking for the speckles.
Yeah, beautiful. The speckling kind of pattern, which I think he has a little
He
bit
had
of.
a little bit, yeah.
So this is the strain.
Yep, so that's a typical cherry on top pattern. That pretty much there will be an apical sparing of the severe diastolic dysfunction. Otherwise, the rest of the walls will be completely involved with amyloidosis.
Beautiful, beautiful. And this is, for everybody who's thinking about sitting exams, this is a real favorite of examiners, like obsessed. I've seen it in the DU exam, I've seen it in the ASC exam. People love asking about the cherry on top strain pattern, and then, the cardiac amyloidosis diagnosis. And Hatton absolutely smashed that. Okay.
So give me a couple. I think there are a couple of other things to look for though on 2D. So you talked about the thickened myocardium, the speckled appearance to it. What else do we need to go and look at? Because I think before we get to the speckling, it's having a look at the 2D. There are other 2D features to look for.
So it will be the basal function compared to the apical function.
Nice. So, and that's what we'd see in the cherry on top thing. It's relative hyperkinesia of the apex relative to the base. Hence, you get the red center and the white exterior, the cherry on the cake. Yep.
And
what else?
left atrial dilation. And,
nice. Yeah. There's often biatrial dilatation. So significant biatrial dilation is Benny's showing there. And there'd be one more feature to look for if you're worried about amyloid, because it's often associated with worse outcomes in amyloid. Pericardial effusion. Beautiful. So just in summary then, for amyloid, it would be thickened myocardium, speckled appearance, but that does get less when you've got harmonic imaging. The significant biatrial dilatation, and then the relative hyperkinesia of the apex of the left ventricle versus the base. And then if there's a pericardial effusion, that's often quite a bad sign.
And for diastology, we kind of skipped through it, but yes, exactly like Hassan mentioned.
Restrictive heart disease.
Yeah, yep. You look at the EA ratio. If you can get with cardiac amyloid, depending on how much it's progressed, you can get anything from mild to severe diastolic dysfunction, and then you just go through your algorithm, which for that you need your EA, your E over E prime ratios, your left atrial index volume, and your TR jet peak velocity.
So maybe the next thing I can say about this is I think that echo is suggestive of amyloid here, but it could be negative. We don't know that for certain, do we?
No.
So you can see, I guess, the pitfalls potentially with this is that all of those echo features may be suggestive of an infiltrative cardiac disease. This would be the way I'd report it. These findings, the biatrial dilatation, the significant diastolic dysfunction, the thickened myocardium, the relative hyperkinesia of the apex, are all suggestive of a potential infiltrative disease. Further investigation warranted. You can see these features with someone who's got horrible renal failure, severe hypertrophy because they've got a messed up aortic valve that's been replaced. And you can get that relative hyperkinesia, and you can make strain look like a cherry on top if you're a little bit off axis. Because remember, if you're a little bit off axis from the apical 4-chamber views, the apex moves more than it should, because in the heart, the apex is fixed and the base moves towards the apex. If you go off axis, they both move towards each other, and an apex can look like it's moving more. So with inadequate imaging, you can make a cherry on top look like that. So one of the other things I like to do is just make sure that you haven't foreshortened your apical view. And the way that I do that is I sort of almost like stick my thumb at the top of the picture, and you see if the apex moves away from your thumb. If the apex moves away from your thumb, that's suggestive of you being off axis, and you could potentially get abnormal looking strain.
Yeah, I think the way I reported this was strain pattern is highly suspicious of cardiac amyloidosis cardiology.